So let's talk about renal disorders now. A lot of these renal disorders are asked in the college exams and the MCQ exams. And of particular interest are renal stones. Invariably, there is one question from renal stones in all exams and even from renal tumors. So in the first module, I'll be talking about the surgical anatomy and I'll be talking about benign disorders of the kidney. And in the second module, I'll talk about renal trauma, renal infections, and we'll discuss renal tumors as well. So before we talk about any of the pathological conditions of the kidney, let's discuss the surgical anatomy, which is relevant for this topic. So regarding the embryology, we know that the kidney is developed from the metanephric buds, and these metanephric buds are going to give rise to the kidney, and the kidney develops in the iliac fossa and it ascends up to the lumbar region. It ascends up to lumbar region. Now, we know that if the lower ends of the kidneys are fused, right? If the lower ends are fused, that is called as a horseshoe kidney. And we'll talk about that slightly later. But if the lower ends are fused, that is a horseshoe kidney, the ascent is restricted. The ascent is restricted by the inferior mesenteric vessels. And because the ascent is restricted by the inferior mesenteric vessels, the fused portion will lie lower down as compared to the normal kidney. So that is one thing which you should remember here. The second thing which I want you to know in the surgical anatomy of kidney is that there can be some humps which are known as dromedary humps. These are physiological lobulations. These are physiological lobulations which can sometimes persist in adults. So these are physiological lobulations which can persist in adults, and nothing is to be done. If dromedary humps are there, we just need to reassure the patient that there's nothing to worry about. Now, regarding the vascular supply of the kidney, we know the renal arteries arise from the abdominal aorta, and the abdominal aorta is slightly towards the left. It is slightly towards the left, whereas the IVC is slightly towards the right. This is the IVC, it is slightly towards the right. Now, if IVC is slightly towards the right, this is the IVC, it's slightly towards the right. We know that the left renal vein will be longer. Okay, these are the kidneys. This is the kidney. This is the kidney here. So the left renal vein is going to be longer because the IVC is slightly on the right side. So left renal vein is longer, and what is the significance of this? This has been asked many times in the exam, that the left kidney is the preferred donor kidney. The left kidney is the preferred donor kidney during transplant because you get longer renal vein which you can then anastomose. So we get a longer renal vein which we can anastomose. That is why the left kidney is the preferred donor kidney during transplant. One more thing which I want you to know, that the renal vein, the left and the right renal veins, these are the veins. The testicular vessels, the testicular vein on the right side drains into the IVC, whereas the testicular vein on the left side, it drains into the renal vein. So left testicular vein drains into the left renal vein. And the significance of this is that we know renal tumors, this I'll talk about later as well, renal tumors can grow along the vein. And when renal tumors grow along the vein, they can block this opening and they can give rise to secondary varicocele. This I've covered in the testicular module as well. So secondary varicocele can occur. Varicocele is dilated, tortuous, pampaniform plexus of veins. Secondary varicocele can occur on the left side if a left renal cell cancer grows along the renal vein and blocks the opening. So this is another point which you should remember for the exam. Now, two more terms which you should know, which have been asked in the exam. One is a nutcracker. This is nutcracker syndrome. So nutcracker syndrome is when the left renal vein is compressed between the superior mesenteric artery and aorta. That is known as nutcracker syndrome. This is different from nutcracker esophagus, which was a motility disorder of the esophagus, and I've covered it in the esophagus module. And the other thing which you should know is a renal collar. What is a renal collar? A renal collar is when the left renal vein when the left renal vein splits to encase the aorta, that is called a renal collar. This is the aorta, and if this is the IVC, the renal vein, the left renal vein is going to split. It splits and it encases it is going to split and it is going to encase the aorta, and that is known as a renal collar. So these are the points in the surgical anatomy which I want you to know. Let's now start talking about the individual disorders, and the first one which we will discuss is renal agenesis. Now, renal agenesis is seen in 1 in 500 to 1000 live births. It is usually unilateral, and when there is renal agenesis, it is also associated with agenesis of ureter and the hemitrigone of the bladder. In some patients, the adrenal gland might also be absent, and in males, there can be undescended testes on that side, and in females, there can be an absent fallopian tube as well. So this is regarding renal agenesis. It is very important, especially in patients where there is a renal trauma, to always see whether the normal kidney is there or not. And even in patients where a transplant is being planned or any renal procedure is being planned, we should always document the normal kidney. I still remember a patient of ours, third year PG, and there was a trauma patient, a massive road traffic accident who would come. And when we explored the abdomen, there was a retroperitoneal hematoma as well. And there was a suspected renal vascular injury. Now, in that patient, we did the imaging, we did a single shot IVU, and we found out that the other kidney is missing, right? It is not there. There's a solitary kidney. So we had to be very careful, and we had to then repair that vessel, and we had to save that kidney. And that patient also was kept on dialysis for some time because the kidney function took some time to recover. So it is always important to document the other kidney as well. The next congenital problem which we need to talk about is duplication of the ureteric system. So sometimes there can be two ureters. So you can see in this image, and the investigation of choice, of course, to find this out is IVU. Now, you've read in radiology, IVU is intravenous urogram. Intravenous urogram, that is the investigation of choice. And here you can see the two ureters. You can see the two ureters which are there. And whenever there is duplication of the ureteric system, the patient has a Weygert-Meyer's rule. Now, what is the Weygert-Meyer's rule? The Weygert-Meyer's rule states that there are two ureters, right? There are two ureters. So the ureter which is draining the normal part, that means the middle and the lower calyces, the green ureter, this green one, is going to open normally into the bladder. This is going to open normally into the bladder. But the ureter which is draining the upper pole, so this purple ureter which is draining the upper pole, this opens more medially and at an ectopic location, right? So the Weygert-Meyer's rule says that the ureter draining the upper pole, or the ectopic ureter, it will open more medially and distally as compared to the normal ureter. It will open more medially and distally and at an ectopic location as compared to the normal ureter. And in males, this usually opens up in the urethra, whereas in females, it opens up in the vagina. And what is the importance of knowing this? Because this is the presentation, right? So the clinical features, supposing there was a female patient who has duplication of the pelvic system. So how will the mother get that child? The mother will get the child and say that this patient has never been dry, right? Why never been dry? Because the ureter which is opening into the vagina, urine will always keep on dribbling out, So there is urine dribbling all the time, but patient can pass urine normally as well. So how can the patient pass normal urine? Because one of the ureters is draining into the bladder. So she will still be able to hold urine and then pass it at one time. But at the same time, continuous dribbling is also occurring into the vagina. These patients are also more prone to urinary tract infections. Now, what is the management of this patient? So this clinical manifestation, this clinical presentation, which I told you is very important because this was asked twice, once in the INI CET exam, once in the All India exam. So this is a typical presentation, and the management is reimplantation of the ectopic ureter. That is the treatment in these patients. Now, sometimes there can be duplication of the pelvic system and there can be a mal-rotated pelvis as well. So normally, if you look at the surgical anatomy of the pelvis, if you look at the surgical anatomy at the rena hilum, the pelvis is the most posterior structure. The pelvis is the most posterior structure. And the vein, the renal vein, is the most anterior structure, right? Is the most anterior structure. And in between you have the artery. So vein is most anterior, then artery, then you have pelvis, which is posterior. But sometimes you can have duplication with mal-rotated pelvis. Duplication with mal-rotated pelvis. That means the pelvis moves anteriorly, and in this case you will get a drooping lily sign, and this has been asked multiple times in the exam. This is a drooping lily sign which is seen when there's duplication and a mal-rotated pelvis. Okay, so this was regarding duplication of the pelvic system, which I wanted you to know. Let's move on to the next condition, that is polycystic kidney disease. So polycystic kidney disease is also a problem which can be of two types. You can either have infantile polycystic kidney disease or adult polycystic kidney disease. In both conditions, there are multiple cysts in the kidney, and as these cysts enlarge, they hamper the function of the kidney. So infantile polycystic kidney disease is autosomal recessive, whereas adult polycystic kidney disease is autosomal dominant. The genetics has also been asked in the exam. Infantile, it is PKHD gene on chromosome 6, whereas in adult polycystic, it is PKD1 or PKD2. PKD1 is on chromosome 16, PKD2 is on chromosome 4. So the square, 4 into 4 is 16. So 4 times 2 is 16. 4 into 4 is 16. That's how you can remember it. Infantile polycystic kidney disease is not compatible with life, and these children usually die because of hepatic fibrosis. Adult polycystic kidney disease is compatible with life, and these patients, as the cysts enlarge in size, they press on the normal renal parenchyma. And they hamper the function. Of the kidney. So the features of adult polycystic kidney disease, this usually manifests in the third decade of life. And the most common feature with which they are going to come is hypertension. So a young patient who comes with hypertension, polycystic kidney disease is one of the differentials which you should always think about, right? It can be renal artery stenosis, it can be a pheochromocytoma, but one of the differentials in a young patient who's coming with hypertension should be polycystic kidney disease. And that is why in young patients who come with hypertension, we usually do an abdominal scan to see whether there are cysts in the kidney or not. Then patients can also come with pain and hematuria. There can be pain and hematuria as well. There can be pain if the cyst ruptures, and if the cyst ruptures, there can be hematuria as well in these patients. You should also know that the disease progresses faster in males. There is faster progression in males as compared to females. Faster progression in males as compared to females. This is another thing which you should know about. Now, there are certain extra-renal manifestations of polycystic kidney disease as well, which you should know for the exam. The most common extrarenal manifestation, this has been asked, are cysts in the liver. This has been asked in multiple exams, that multiple cysts can form in the liver as well. There can be cysts in the spleen, pancreas and lungs also. Colonic diverticulosis, mitral valve prolapse can be there, and very importantly, there can be berry aneurysms in the circle of Willis. And these berry aneurysms, if they rupture, they can give rise to subarachnoid hemorrhage. Right? So you should know the extrarenal manifestations, and you should know the most common are cysts in the liver. Now, to diagnose polycystic kidney disease, a simple ultrasound is good enough. And this ultrasound can pick up polycystic kidney disease even in the prenatal period. When the child is still in the mother's womb, it can be picked up at that time as well. So in ultrasound, we will see multiple cysts in the kidney. And a prenatal scan, if more than 3 cysts, whether unilateral or bilateral, that clinches the diagnosis of polycystic kidney disease. Or if there are more than 2 cysts in both the kidneys, then also we clinch the diagnosis of polycystic kidney disease. We have to closely monitor the renal function in these patients because as the disease progresses, the renal function is going to deteriorate. So you can see here, this was a CT which was done, and you can see multiple cysts in both the kidneys. So this was a case of polycystic kidney disease. Now, polycystic kidney disease, the nature or the course of the disease is that there will be gradual decline in renal function. There will be gradual decline in renal function as the cysts enlarge in size. And as the cysts enlarge in size and the renal function drops, what are the treatment options which we have? So management for these patients, they can be put under long-term dialysis therapy. Or the patient can go for a renal transplant. Ultimately, they will land up with renal transplants. And you should also know a new modality for treating these patients is vasopressin receptor antagonist. Vasopressin receptor antagonists can also be used to manage these patients. So these are the management options. You should know that Rovsing's procedure, this was asked in the exam many years back, Rovsing's procedure, that is de-roofing of the cyst. So they earlier thought that if you de-roof the cyst, then the pressure will reduce. But they found out that de-roofing of the cyst is not useful. It does not help in improvement of the renal function. One final thing which you should know, that these patients with polycystic kidney disease, 20% patients can also develop stones in the kidney, and these stones are usually uric acid stones. Another condition is multicystic dysplastic kidney. There are multiple cysts in the kidney. They can be unilateral or bilateral, and if they are bilateral, it is not compatible with life. Unilateral patient will come with an abdominal lump at birth, and in adults, there's rapid progression to renal failure. There are no surgical options for multicystic dysplastic kidney. Only conservative management can be done. If there is a decline in renal function, then dialysis or transplant can be carried out in these patients. Another congenital problem in the kidney is horseshoe kidney. And I told you horseshoe kidney is when the lower ends of the kidney are fused. That will give rise to a horseshoe kidney. And because the lower ends are fused, normal ascent of the kidney does not take place. And the fused portion usually lies at the level of L3 and L4, and the ascent is restricted by the inferior mesenteric vessels. This I told you in the start only. So now, how does a patient of horseshoe kidney present to us? So the clinical features, majority are asymptomatic, right? And they are incidentally detected. Some patients can come with a palpable mass, and this palpable mass which you're feeling is the fused portion, which you will usually feel at the level of L3, L4. Now, these patients are more prone to infections. And especially infections during pregnancy. Now, in these patients, there can also be kinking of the ureter. And if there is kinking of the ureter, then there can be hydronephrosis or stone formation, which can give rise to pain as well. And these patients can also develop stones. So the patient can also present with pain. These are the other presentations in a patient with horseshoe kidney. Now, the diagnosis of horseshoe kidney is based on an IVU, that is intravenous urogram, or you can even do a CT to see the diagnosis. So the investigation of choice for horseshoe kidney is an IVU, intravenous urogram. And when we do the intravenous urogram, you will get the typical flower vase appearance or the handshake sign. So this is the sign which you get a flower vase sign or a handshake sign is what we see on intravenous urogram. Okay. Now, the management of a patient with horseshoe kidney, if the patient is asymptomatic, no management is required. But if hydronephrosis is there, if there is hydronephrosis, or if there is a malrotated pelvis which is giving rise to stone formation as well, then in these patients we have to carry out pyeloplasty, right? Then we have to carry out pyeloplasty. One thing which I want you to remember is we never cut the fused portion. We never cut the fused portion. And why don't we cut the fused portion? So never cut the fused portion, and the reason for that is if we cut this fused portion, you will end up devascularizing the lower ends of both the kidneys, and we don't want that, right? So we don't cut the fused portion. The only exception where the fused portion is cut is a patient with horseshoe kidney, with a symptomatic abdominal aortic aneurysm. And I've told you in the vascular module that to approach the aorta, we will now have to cut the fused portion. Then only we can approach the abdominal aortic aneurysm. So that is the only exception where the fused portion is cut. Otherwise, we don't cut the fused portion in a horseshoe kidney. The next topic which we need to discuss is hydronephrosis. Now, hydronephrosis is very important. The individual topics are asked as short notes. In your university exam, it can be asked as a long question as well. And there are a lot of terms in hydronephrosis which are even asked as MCQs. So what is hydronephrosis? Hydronephrosis is the aseptic dilatation of the pelvicoleseal system due to intermittent, partial or complete blockade to the flow of urine. So if there is a blockade to the flow of urine, there will be back pressure changes, and that would give rise to hydronephrosis. Now, hydronephrosis can either be unilateral or it can be bilateral. In unilateral also there can be intraluminal, intramural and extraluminal causes. So first let's talk about intraluminal causes in unilateral hydronephrosis. So unilateral causes, we are first talking about intraluminal causes. That means within the lumen. So intraluminal, the most common cause of acquired hydronephrosis. The most common cause of acquired hydronephrosis is the presence of renal stones. So renal stones are the most common cause of acquired hydronephrosis, and this question has been asked multiple times in the exam. The other intraluminal causes can be sloughed papillae, and sloughed papillae can be seen in patients with diabetes mellitus and in patients who abuse analgesics, so analgesic abuse. These are the patients where we can get sloughed papillae as well. So these were the intraluminal causes of hydronephrosis. There can be intramural causes as well. Intramural means within the wall. And within the wall, the most common congenital cause of hydronephrosis, or the most common cause of hydronephrosis in children, is PUJ obstruction. Pelviureteric junction obstruction, right? This is pelviureteric junction obstruction, and it is a functional obstruction. That means there is no physical obstruction to the flow of urine. So no physical obstruction is there, but the uretropelvic junction is not contracting. Right? In normal patients like us, in normal people like us, it contracts and it pushes the urine forward. But if the uretropelvic junction does not contract, there will be a functional obstruction, and that is PUJ obstruction. So pelviureteric junction obstruction, the investigation of choice is a MAG3 scan, which tells us how much function is left in that kidney. And this MAG3 scan I will cover slightly later. I will tell you about the various types of scans which are done in patients with hydronephrosis and what do we infer from the scan. Right now you can just note down that MAC3 scan is done. And in patients with PUJ obstruction, if they are symptomatic, the surgery which is carried out is called Anderson-Hines dismembered pyeloplasty. So the name of the surgery is Anderson-Hines dismembered pyeloplasty. This is the surgery done for PUJ obstruction, pelviureteric junction obstruction, which is one of the intramural causes of hydronephrosis, and this is the most common congenital cause as well. Another intramural cause is transitional cell carcinoma of the pelvis or transitional cell carcinoma of the ureter. So this cancer which arises from the wall can block the flow of urine and can give rise to back pressure changes. Now, TCC of the ureter, there is a peculiar sign on intravenous urogram, and this is known as the goblet sign. So goblet sign is seen in transitional cell cancer of the ureter or the pelvis. And this is the goblet sign which you will get. You can see here that you get a goblet sign like this. It looks like a goblet in which you can drink alcohol. So it looks like a goblet. This is another intramural cause which you should know. Another very important intramural cause is ureterocele. This has been asked in multiple exams, and in the last 5 years, I feel at least 3 or 4 times this has been asked. And ureterocele is defined as the dilatation of the terminal ends of the ureter. Dilatation of terminal ends of the ureter. That is known as ureterocele. And in 10% patients, this can be bilateral. In 10% patients, this can be bilateral as well. And ureterocele patients will present with hydronephrosis, and on IVU you get a peculiar feature here, that is cobra head or adder head sign. So you get the cobra head or the adder head sign on IVU, cobra head or adder head sign, which you can see here. This has been asked, this image has been asked in all possible exams. This condition you should know is more common in females as compared to males. I told you 10% can be bilateral, and the management of these patients is excision of the terminal end and reimplantation of the ureter. So we have to carry out reimplantation of the ureter by after excising the terminal ends of the ureter. Endoscopic incision can also be given. Endoscopic surgery can also be done, but when endoscopic surgery is done, there are high chances of reflux, which is why traditional surgery is preferred. There are high chances of reflux in these patients. So you should know about ureterocele. Ureterocele is also a very important question from the point of view of the exam. So we've covered intraluminal causes, we've covered intramural causes. Now we move on to the extraluminal causes. That means causes outside the lumen. So extraluminal causes of hydronephrosis. And these extraluminal causes, first one are aberrant renal vessels. So these aberrant renal vessels are usually unilateral, and they can compress the pelvis from outside, okay, and they can give rise to hydronephrosis, or they can compress the ureter from outside. So they're usually unilateral, and we should never cut the aberrant vessel. Never cut the aberrant vessel, as it can devascularize a portion of the kidney. So we don't cut them. The treatment which is done in these patients is called pyeloplasty. We will carry out a pyeloplasty, but we don't cut these aberrant renal vessels which are there. So this was one extraluminal cause. Now other extraluminal causes can be advanced cancers. And which advanced cancers can give rise to hydronephrosis? So they will usually give rise to hydronephrosis by pressing on the ureter. Right, and just the other day, we saw a case where this patient had a huge soft tissue sarcoma in the retroperitoneum, and that was encasing both the ureters, because of which the patient had bilateral hydronephrosis. So advanced cancers like soft tissue sarcomas in the retroperitoneum, or it can be an advanced uterine cancer, it can be an advanced cervical cancer, carcinoma cervix, so CA cervix, or it can be a CA colon, So these are some cancers which can give rise to hydronephrosis. Even CA prostate, advanced CA prostate, CA rectum can also give rise to, they can give rise to hydronephrosis. And the primary modality is to manage the primary cancer. But like this sarcoma which I was telling you, so what we did was we put in stents in the ureter before the sarcoma was excised, so that we don't injure the ureter and the ureters remain patent as well. The other causes of extraluminal hydronephrosis, you can have a retrocaval ureter. This is also a very important cause, and the image has been asked in the exam. So retrocaval ureter is seen on the right side. When the right-sided ureter goes behind the IVC, that is a retrocaval ureter. So when the right-sided ureter goes behind the IVC, that is known as a retrocaval ureter. So you can see here, this is a retrocaval ureter which is there, and this gives rise to, on IVU, a fish hook or a reverse J abnormality. A classical, so on IVU, you will get a fish hook sign, and these signs are important, a fish hook sign, or you get a reverse J sign. You get a reverse J sign. So this is what we get in a retrocaval ureter. So management of these patients is we do lateralization. We do lateralization of the ureter. And if lateralization of the ureter does not work out, then the only option is that we cut that segment and we do a ureterostomy. We do a ureterostomy. We anastomose the two ends of the ureter and we bypass that segment which is there. So that is the management of retrocaval ureter, which is another an extraluminal cause of hydronephrosis. The final extraluminal cause which I want to talk about is retroperitoneal fibrosis. And retroperitoneal fibrosis also has been asked multiple times in the exam. Retroperitoneal fibrosis is also known as Ormond's disease. It is known as Ormond's disease, and there are multiple causes of retroperitoneal fibrosis. It can be idiopathic, or it can be associated with certain drugs. These drugs have been asked in the exam. They are methisergide and bromocriptine. Methisergide has been asked in the exam. Now, this retroperitoneal fibrosis can also be IgG4 mediated. Remember, there are multiple places where we've spoken about IgG4, that it causes fibrosis. We've spoken about it in pancreatitis. We've spoken about it in Peyronie's disease, Dupuytren's contracture, in Riedel's thyroiditis. So all the places where fibrosis is occurring, one of the causative factors can be IgG4 mediated. And you can see it can be associated with Dupuytren's contracture and Peyronie's disease. It can also be present post-radiotherapy. Now, in retroperitoneal fibrosis, the first structures to be involved are the ureters. And this question has also been asked in the exam. So now, when there is fibrosis in the retroperitoneum, these ureters will come close to each other. Because of the fibrosis, they will come close to each other. Whereas if it was a sarcoma, they'll be splayed or they'll be pushed apart. Whereas when fibrosis, these ureters come close to each other and there can be pressure on the ureter from outside. Now, because these ureters come close to each other, when we do an IVU, intravenous urogram, you get a typical anomaly that is known as maiden's waist anomaly, right? It looks like the waist of a female. So maiden's waist anomaly or maiden's waist abnormality, this is seen in retroperitoneal fibrosis, and this question has also been asked in the exam. Now, the management of retroperitoneal fibrosis, we don't want the ureters to be affected more, otherwise the hydronephrosis will increase. So the management is we put in DJ stents. DJ stents are double J stents, and I will talk about them at various places. These are double J stents which are put in. These are not worms, you can see these are not worms. These are stents which are put in both the ureters so that the ureters can be kept patent. In addition to this retroperitoneal fibrosis, the management, we can give steroids in these patients, and we have to also manage the primary causative factor which is leading to retroperitoneal fibrosis. So this takes care of all the unilateral causes of hydronephrosis. We've discussed the unilateral causes right from intraluminal to extraluminal causes. Now, there can be bilateral hydronephrosis, which can be there as well. And the causes of bilateral hydronephrosis can be any unilateral cause on both the sides, or there can be causes which are beyond the opening of the ureters. So, understand this point, please. These are the ureters which are opening into the bladder. These are the ureters opening into the bladder. This is the bladder, and then you have the urethra. Now, if there is any cause which occurs beyond this point, say here, 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 or here, then it will give rise to bilateral hydronephrosis. So what are these causes? There can be benign prostatic hypertrophy. There can be BPH. There can be bladder outlet obstruction, posterior urethral valves, which I've already covered in the urethra module. There can be phimosis, which also has been covered in the penile module, urethra and penile module. Phimosis is inability to retract the foreskin. And there can be meatal stenosis as well. So these are the bilateral causes which you should know for your exam. Now in hydronephrosis, what is the imaging which tells us that the patient is developing hydronephrosis? So we can do an intravenous urogram, and when we do an intravenous urogram in hydronephrosis, a normal kidney, the calyces are cup-shaped. Normal kidney, the calyces are cup-shaped. The first thing which happens in hydronephrosis is that there is blunting of the calyces, right? That there is blunting of calyces. And following blunting of calyces, there can be clubbing of calyces. Okay, there can be clubbing of calyces. So there can be clubbing of calyces which can be seen. Initially there's blunting and then clubbing. So you can see on this side you can see that the calyces are cup-shaped. You can see the calyces are cup-shaped. But here the calyces are becoming clubbed. Here the calyces are becoming clubbed. Let's see another picture where this would be better visualized. You can see here that here the calyces are cup-shaped. They are normal. But here can you see the massive clubbing which is occurring of the calyces here. So this is representative of hydronephrosis. Now, to manage a patient with hydronephrosis, we need to see the functioning of the kidney. Renal function analysis is very important in these patients. So, there are certain renal isotope scans which are done in patients with hydronephrosis. So, renal isotope scans are done, and there are 3 scans which are done. You can do DMSA, it can be DTPA, and it can be MAG3 scan. These are the 3 renal isotope scans which are normally done. Out of these, DMSA, S you can remember for structure or scarring. S you can remember for structure or scarring. So this tells us about anatomical points as well, whether there's scarring of the kidney, any structural abnormalities are there or not. And DTPA and MAG3 tell us more about the function. Okay. And out of these, MAG3 is the best for function. This question has also been asked in multiple exams. This is the best for the function of the kidney. To analyze the function of the kidney, a MAG3 scan is the best scan. Now, when this scan is done, you can see here, this is how the scan looks like. And you will see if the kidneys are taking up the dye or the contrast, and how much are they eliminating it as well. So when we do the renal isotope scans, what we get to know is the total GFR. We will get to know the total GFR, and we also get to know what is the differential GFR. Now, what does that mean? So let's assume that the total GFR is 100. Okay, let's assume the total GFR is 100. Now, differential GFR would be that how much is the right and the left kidney contributing to this 100, right? So I will get a value like 90 is right and 10% is left. So of course, left is the affected kidney or the hydronephrotic kidney. So diseased kidney, that is just contributing 10% to the total GFR. Whereas right kidney is working 90%. 90% of the contribution is coming from the right side. So we get to know the total GFR and the differential GFR. Now, once we've done this, what do we decipher from this and how does it affect our management? So, in any patient who has hydronephrosis, any patient where there is hydronephrosis, if the hydronephrotic kidney if the hydronephrotic kidney is contributing more than 20% to total GFR. Okay, if the hydronephrotic kidney is contributing more than 20% to total GFR, we should save the kidney. We should save the kidney, so we need to just take care of the primary abnormality which is giving rise to hydronephrosis. So if it is a stone, deal with that stone. If it is retroperitoneal fibrosis or ureterocele, deal with that. But we need to save the kidney because it still has some meaningful function left. Now, if the hydronephrotic kidney is contributing 10 to 20% to total GFR, then in these patients, we carry out a nephrostomy, right? In this kidney, we'll do a nephrostomy in addition to, of course, treating the primary condition. Now, after doing the nephrostomy, if the function improves, then we will save the kidney. But if the function deteriorates or remains the same, if the function goes down or remains the same, then there is no point saving the kidney. Okay? Then there's no point saving the kidney. And finally, if the hydronephrotic kidney is contributing less than 10% to total GFR, then in these patients, we should carry out a nephrectomy. Then in these patients, a nephrectomy should be done. So that is how we manage patients with hydronephrosis. It is a very, very important topic for the exam, often asked as a long question in the college exams as well. Now moving on to another topic which is super important, and invariably there is one question in every exam from this topic, that is renal stones. Now renal stones, how do these stones form? So ultimately, formation is going to occur by supersaturation. Whenever a compound gets supersaturated in a solution, then it is going to precipitate and it is going to form crystals and eventually a stone. So there are certain terms which I want you to know here, which have been asked in the INI exam or the AIIMS and the JIPMER exams previously, and in the super specialty exams as well. The first term is the concentration product. Now, this is something which we read in our chemistry in school as well. This is the amount of solute in a solution, that is the concentration product. Saturation product is the maximum amount of solute in a solution. Okay, maximum amount of solute in a solution will be saturation product. Now, common sense would say that if you go over the saturation product, then stone formation will start. But that is usually not the case in human beings because there are certain stone inhibiting factors as well, right? So what is formation product? Formation product is the maximum concentration of solute in a solution after taking into account stone inhibiting factors. And what are these stone inhibiting factors? The most common or the most important is citrate. And the other ones can be Tom phosphoprotein. Tom phosphoprotein are also these are examples of stone inhibiting factors. The most important is citrate. So once you factor in the stone inhibiting factors as well, you get the formation product. Now, if the concentration product is more than the formation product, that means it is a super saturated solution. That is what is going to lead to stone formation, or that will be the trigger for stone formation in the kidney. Now, before we talk about the individual types of renal stones, I just want to share an image with you. This is the image of Stonehenge. So Stonehenge is a place, it is a couple of hours drive from London, and you have these big rocks which have been arranged in different patterns. And researchers have been trying to figure out since ages that why these rocks were kept in this place. So it's quite a tourist attraction, but when you go there, you just see some big pieces of rock kept randomly. So, but it was on my bucket list. So we did go there when I went there for my MRCS convocation. And this is just an image of the Stonehenge, which I wanted to show to you before we start discussing the individual stones. Now, the first type of stone which we need to discuss in under renal stones are calcium oxalate stones. So calcium oxalate stones are the most common renal stones which are there. And these are formed in acidic urine. They are formed in acidic urine. Now, calcium oxalate stones, the Crystals of calcium oxalate stones, you can either have calcium oxalate monohydrate stones, or you can have calcium oxalate dihydrate stones. Okay. So monohydrate and dihydrate stones can be there. Monohydrate stones are dumbbell shaped, right? They are dumbbell shaped like the dumbbells which you pick up in the gym. So they are dumbbell shaped, whereas dihydrate stones are envelope shaped, crystals. Okay. So these are the crystals of these calcium oxalate stones. And calcium oxalate monohydrate stones are very hard stones. They are very hard stones. And this you can easily remember just by remembering dumbbells. Now, even if you drop a dumbbell on the floor, the dumbbell does not break because it is very hard. Also, these calcium oxalate stones, they have spiculated margins, right? They have spiculated margins, and because they have spiculated margins, they are sometimes known as mulberry stones as well. They are known as mulberry stones. Now, it is common sense that if there are spiculated margins, because of the spiculated margin, the patient is going to come with pain and hematuria early. Right? There will be early pain and hematuria because of these spicules which are there. Early pain and hematuria would be present in these patients. So this is regarding calcium oxalate stones. Now these stones are radio-opaque in nature. They are radio-opaque stones. Calcium oxalate stones are radio-opaque, and sometimes patients can develop recurrent calcium oxalate stones. Now, whenever the patient is developing recurrent stones, we always do a urine analysis or crystal analysis to see what kind of stone is there and what kind of dietary advice or medical management we can give to the patient to prevent stone formation in the future. So the dietary advice which is given in recurrent calcium oxalate stones, we tell the patient to decrease the fat content, increase the calcium intake in the diet. Now, this is something which is where a lot of students get confused. They think that if it is a calcium oxalate stone, then the calcium content, if it is low in the diet, then stone formation will be less. But that is not the case. If the calcium content is higher, more amount of oxalate is going to be chelated in the gut itself, and less oxalate will be absorbed. Okay, so that is why higher calcium content is recommended, so that less oxalate absorption occurs from the gut. Large doses of pyridoxine and cholestyramine, which binds oxalate in the gut and reduces the incidence and absorption, is also recommended in patients who are developing multiple recurrent calcium oxalate stones. The second type of stone is a triple phosphate stone. The other names for triple phosphate stones are a staghorn stone, right? They are a staghorn, also known as struvite stones. So these are other names which you should remember for the exam as well. Now, the chemical composition is calcium, magnesium, ammonium phosphate, and these stones are formed in alkaline urine, which is usually infected with Proteus. It is usually infected with Proteus. So it is infected urine, and Proteus is the most common organism responsible for this stone formation. Now, these triple phosphate stones, the crystals of triple phosphate stones are coffin lid type. They are coffin lid type. So there was a line in the Old Bailey, and the Bailey of my father, such an old Bailey. When I read them, there's some very interesting lines written there. And one of the lines written there was that a renal stone is nothing but a tombstone laid in the memory of the bacteria which lay beneath them. Right? So all they are trying to say is that when that bacterial infection occurred, so to cover up that bacteria, the body started forming stones. So aptly, the crystal will also be a coffin lid type of crystal. To bury that bacteria, you need a coffin lid. That's how you can remember the crystal of triple phosphate stones. Now, these stones have a smooth, dirty white surface. They have a smooth, dirty white surface as opposed to oxalate stones where there were spiculated margins. So because it's a smooth, dirty white surface, they can increase in size. They can increase in size before they become symptomatic. Before they become symptomatic, they can increase in size. Okay, so you can see here, this is a staghorn stone. You can see how big it is. And I often tell students that if you see a paperweight on your surgery professor's desk, it can only be two types of stones. Either it's a bladder stone or it's a staghorn stone. Only those stones will reach such a size to form a paperweight. Okay. And staghorn, so you've seen male deers, they have these, the male deers are called stags. So you can see the horn, here. And this was a picture clicked by me in Bandipur, where you can see this beautiful stag and the horns on the top. And you can see this is how the shape of the staghorn stones are also when you see it in imaging. Okay. Now, if the patient is developing recurrent triple phosphate or struvite stones, then in these patients, the medical management is acetohydroxamic acid. Acetohydroxamic acid can be given if the patient is developing recurrent stones, recurrent triple phosphate stones. Okay, so this was regarding triple phosphate or staghorn stones. Next one are cystine stones. So cystine stones are also radiopaque stones, and they are very hard stones. They have a very hard crystalline lattice. So their crystal structure is hexagonal. It is crystalline lattice, and it is very difficult to break by ESWL. ESWL is extracorporeal shock wave lithotripsy. I'll talk about this later. This is one of the treatment modalities for renal stones. It is extracorporeal shock wave lithotripsy, and these stones usually don't break up by ESWL. This condition can be seen in cystinuria, and if you have recurrent cystine stones, then D-penicillamine can be used in these patients. D-penicillamine can be used in these patients. Before I talk about uric acid stones, I just want to show you the microscopic appearance of these crystals. And remember, I told you staghorn or struvite stones. You can see coffin lid type of appearance. So this is coffin lid type of crystals. These crystals you should remember because they've been asked multiple times in the exam. They've shown an image of the crystal and they've asked which stone is the patient suffering from. These are cystine stones. Cystine stones, I told you, are hexagonal in shape. They have a crystalline lattice. These are uric acid crystals. We haven't read about uric acid. Uric acid crystals are going to be like glass shards. So you know when glass breaks, right? If you accidentally drop glass, it is going to fragment into various shapes and sizes. So that is what uric acid crystals also look like. Calcium oxalate monohydrate, I told you, are dumbbell shaped, and dihydrate are envelope shaped, right? And this is the most common renal stone. And ammonium urate stones can be seen in patients with laxative abuse. Ammonium urate, you should know this. Ammonium urate stones can be seen in patients with laxative abuse. It can also be seen in patients with inflammatory bowel disease. So Crohn's disease also, patients also can develop ammonium urate stones. Now, uric acid stones are the most common radiolucent stones. So up till now, we were talking about radio-opaque stones. But this is the most common radiolucent stone which will not show up on an X-ray. And uric acid stones, I've already told you, the crystals will be like glass shards. Crystals will be like glass shards, so all random patterns. And they are also formed in acidic or non-infected urine. Now, uric acid stones can be seen in conditions like tumor lysis syndrome, in patients with tumor lysis syndrome, and they can also be seen in patients with gout. Now, if the patient is developing recurrent uric acid stones, so if the patient is developing recurrent uric acid stones, then in these patients, allopurinol can be used as medical management, right? So allopurinol can be used as medical management in these patients. So these were the various types of stones. There are certain rare types of stones as well, which I want you to know, which have sometimes been asked in the exam. I want you to know xanthine stones. Xanthine stones are brick red in color. Triampterine stones are also there. They are also rare, but triamterene stones can also be there. And you can have indinavir stones also. Now, indinavir is an antiretroviral drug, and one of the side effects of this antiretroviral drug is stone formation. So there are certain rare types of stones as well. You can have xanthine stones, which are brick red. You can have triamterene stones as well. And there can be indinavir stones. Indinavir stone are radiolucent. In fact, all these stones are radiolucent, which I've mentioned. All stones are radiolucent. And indinavir is an antiretroviral agent. And one of the side effects of this antiretroviral agent is radiolucent stone formation. I still remember there was a friend of mine. We both were posted as interns in the medicine ward. And he got a pinprick with a patient who was HIV positive and the CD4 count was very low. And the pinprick happened because he was capping the needle like this. He was putting his hand on the cap and putting the cap back, which is what you should never do. You should do it in the contactless method so that you don't get a pinprick. Now, when he had this prick, the patient passed away the next day and he was started on anti-exposure prophylaxis. And one of the medicines given was indinavir. And I remember 1 month later, he was in such a terrible shape with all the myalgia. And he also developed indinavir stones, which caused him a lot of trouble as well. So these are the various types of stones which you should know. I've covered the common types and the rare types of stones as well. Now, how does a patient with renal stones present to us? So patients can be asymptomatic as well, but the most common presentation of renal stones is pain. The most common presentation of renal stones is pain. Now, this pain which the patient has can be of two types. It can either be fixed renal pain, or it can be colicky pain. The fixed renal pain is because of distension of the renal capsule, and this is felt at the renal angle. This is where this pain is felt. The colicky abdominal pain depends on the site of the stone. Now, if the stone is in the renal pelvis, or the stone is in the upper ureter, then in these patients have the typical low-end to groin type of pain. Through the upper ureter, the patient can also have pain along the obturator nerve, and this pain will be felt along the inner aspect of the thigh. It will radiate to the inner aspect of the thigh. Now, if the stone is in the upper or the mid ureter, then pain can also radiate along the iliohypogastric nerve. Pain can be there along the iliohypogastric nerve as well. If the stone is in the lower ureter, then pain can be along the ilioinguinal nerve. Then pain can radiate along the ilioinguinal nerve. And if the stone is impacted in the intramural portion, that means when the ureter is opening into the bladder, then the patient can come with strangury. And what is strangury? Strangury is an intense urge to pass urine. A painful urge to pass urine. But when the patient goes to pass urine, the patient is only able to pass 1 or 2 drops of bloody urine. Okay, so that is strangury, intense painful urge to pass urine. But when the patient goes to pass urine, just 1 or 2 drops of bloody urine are passed, and this occurs when the stone is impacted in the intramural portion. The other presentations of renal stones, I told you, they are the most common acquired cause of hydronephrosis. I've already covered hydronephrosis with you as well. Patients can also come with Dietl's crisis. Dietl's crisis has also been asked in the MCQ exam. So what exactly is Dietl's crisis? Dietl's crisis is if this is the kidney, and this is a stone which is blocking the pelvis. So the stone blocks the pelvis, and when this happens, urine will accumulate inside the kidney, right? When the stone blocks the pelvis, urine accumulates inside the kidney and the kidney capsule is going to distend, right? So the patient is going to come with pain at renal angle. There can be pain at the renal angle and there can be a palpable swelling. There can be a palpable swelling which can be felt as well. Okay. But after some time, this stone will shift its position. Stone shifts in position. And when the stone shifts in position, what is going to happen now? This was the kidney. This was the kidney and now the stone has shifted in position. So all the urine which was accumulated, now the urine will come down and the swelling will subside. So after some time what happens? That the swelling subsides and patient passes large quantities of diluted urine. Large quantities of diluted urine are passed and this is known as Dietl's crisis. Okay, so this is another presentation of renal stones which you should know about. So we've discussed the presentations as well. Patients can also come with hematuria because of these stones. Hematuria can also be there. And I told you calcium oxalate stones which have spiculated margins will present with hematuria earlier. Now, what are the investigations to diagnose renal stones? And you should know here that the investigation of choice is NCCT, non-contrast CT scan of the abdomen, or NCCT-KUB is the investigation of choice for renal stones. It is not CECT, it is non-contrast. What are the other areas where we spoke about non-contrast CT? Head injury and salivary gland stones. Even there, non-contrast CT scan was the investigation of choice. And this is particularly important for final year students. If you're asked in the Viva, please don't say IVU. IVU is not the investigation of choice, because when we do an IVU, because of the dye, everything is going to appear white, right? How can you differentiate that from a stone? And it is not ultrasound KUB also, because ultrasound KUB is not sensitive for the lower part of the ureters. The lower part of the ureters are usually not visualized because of bowel gas in front of them. That is why the investigation of choice is a non-contrast CT scan. Now, how do we manage patients with renal stones? So the management principles which you should remember, that if patient is asymptomatic, if the patient is asymptomatic and the stone is less than 5 to 6 millimeters, then in these patients we just need to do observation. We just need to do observation, okay? Nothing else. You know, you'll have people giving you a lot of advice, and everyone in India is never short of health advice. So whether they are a doctor or not, they will definitely give you advice. Some people will say that go have beer. Somebody will tell you to drink more water. So whether the patient has beer or does not have beer, these small stones will pass on their own. You don't need to worry about them. Now, if the stone is more than 5 to 6 millimeters, and patient is symptomatic, right, and or patient is symptomatic, then in these patients, the first line of treatment is ESWL. So the first line of management is ESWL. ESWL stands for extracorporeal shock wave lithotripsy. Extracorporeal shock wave lithotripsy. Okay. So extracorporeal shockwave lithotripsy, this works on the principle of blast wave dynamics. Blast wave dynamics means that if you have a stone and if you direct ultrasonic waves on this stone is going to shatter into smaller pieces. Okay. Another common example of blast wave dynamics, I'm sure all of you must have seen movies, whether they're Hindi movies or local movies. You must have seen that the hero punches the ground or he just punches in the air and a wave goes and multiple people are flying. Okay, so that is a blast wave, and similar blast waves can shatter stones as well. This is the ESWL apparatus which is there. So this is the ESWL apparatus, and you can see the patient has to lie here and the patient has to lie still so that the waves can be directed at the right place. Now, one of the strongest ESWL apparatus was the Dornier's apparatus. It is one of the strongest ESWL apparatus which was used initially. Now, extracorporeal shockwave lithotripsy is going to shatter the stone, and these fragments are going to travel down the ureter. So what are the complications of ESWL? So let's see here that this was our stone, and when we shatter the stone, these fragments are going to travel down. And when they travel down, they will give rise to pain. So pain is the most common complication of extracorporeal shockwave lithotripsy. Again, when these fragments are traveling down, they can cause abrasions, and that can give rise to hematuria as well. Now, sometimes what can happen that multiple stone fragments can be generated, and these multiple stone fragments can completely clog the ureter, and when they clog the ureter, they are going to give rise to a stone street, and this is known as Stenstrasse. So sometimes multiple fragments of these stones can be generated, and they can completely clog or block the ureter, and they can give rise to a stone street, and this is also known as Stenstrasse. This is also known as Stenstrasse or stone street. So if you've seen a cobblestone street, you have multiple stones packed in that street, and that is the kind of appearance which you can get. Also, this can predispose to urinary tract infections. So these are the complications of ESWL which you should know about. Also in ESWL, multiple sittings are required. If it's a large stone, you cannot shatter the stone in one sitting. So multiple sittings are required, and patient compliance is required to attend those multiple sessions as well. Now, all patients cannot undergo ESWL, and there are certain contraindications for ESWL as well. Contraindications are pregnancy, uncontrolled bleeding disorder, if the stone is more than 1.5 centimeters in size, although multiple sessions can be done and these stones can be shattered, but usually more than 1.5 centimeters in size, we look at other modalities. If the patient has a cardiac pacemaker, children, this has been asked in the exam. Why children? Because children don't lie still, they just keep on moving. So you can't direct the waves at one particular point. Obese patients, again, delivery of the ultrasonic waves is a challenge. That is why obese patients also, it's a relative contraindication. Another thing which has been asked are very hard stones. And I told you there are two types of stones which are very hard. You have cysteine and you have calcium oxalate monohydrate stones. So cysteine and calcium oxalate monohydrate, they usually don't get broken up by ESWL. Very important for you to understand is an obstructed system. Right? So obstructed system means here that if supposing this is the stone which is here and there is an obstruction distally in the ureter. So even if I shatter the stone, the fragments are going to come and get stuck here. So an obstructed system is also a contraindication for ESWL. So is a lower calyx stone. Why is a lower calyx stone a contraindication? So lower calyx stones, supposing the stone is here. Now, even if I shatter this stone, the fragments have to travel anti-gravity to reach into the pelvis. And it is difficult for these fragments, all of them, to travel anti-gravity, which is why a lower calyx stone is also a relative contraindication for extracorporeal shockwave lithotripsy. So you should know these contraindications because they've been asked in various exams as well. Now, if ESWL is contraindicated, then we have two options. We have PCNL and we have URS or RIRS. Okay. What do these mean? So PCNL means percutaneous nephrolithotomy. Percutaneous nephrolithotomy is PCNL. Okay, so I will show you a video of PCNL, but just a simple description of PCNL is that if this is the kidney, and this was our stone which is here, this was the stone, this is the skin. So under image guidance, I am going to put a guide wire and then a catheter right next to the stone. And through this, I'm going to put in a nephroscope and I'm going to shatter the stone and I'm going to remove the stone. So we are directly puncturing the parenchyma and we are going right next to the stone. That is PCNL, percutaneous nephrolithotomy. This is done under image guidance. And let me now show you a clip of PCNL regarding how it's done. So this demonstrates a PCNL. In PCNL, first we do a cystoscopy and we put in a Foley's and a ureteric catheter. You can see here the ureteric catheter, it is going through the ureteric opening. So that is the Foley's and the ureteric catheter which has been inserted. That is the first step when we are about to do a PCNL, that is percutaneous nephrolithotomy. Okay. Once this has been done, then under fluoroscopic guidance, we are going to use a needle and we will puncture the dilated calyces, and we are going to, so that is the needle which is being inserted, and we're going to puncture the dilated system which is there. You can see here we've punctured the system. This is the stone and we've come close to the stone. So now the puncture has been made, and once you make the right puncture, urine will start coming out. So we know we are in the right place. Now we are going to put in the guide wire, right? That is the guide wire. You can see the guide wire going in. And once the guide wire has gone in, we are going to put the sheath on top of that. So that is the guide wire which is going in. And now you will see we are going to put the sheath over this. So this is the sheath which is being put, and through the sheath will go our nephroscope. And via the nephroscope, we'll then be able to see the stone and deal with the stone. So you can see now the sheath has gone in, it is close to the stone, and now we are putting in our nephroscope. This is our nephroscope which is going in through the sheath. Now we go close to the stone. So we're going to go close to the stone, we're going to break up the stone, and we will remove the fragments. So you can see here, you can see the stone. There you can see bits of the stone which are there. Now they're going to be grabbed and the stone fragments are going to be removed. There the stone has come. There you can see the stone. It has come in the scope through the instrument which you've put in. You can break the stone and then you can retrieve the fragments. And you will now see the urologist bringing out the stone and its fragments. So there you can see the stone fragments have been removed. There you can see the stone fragment has been removed, and you'll keep on doing it again till everything is clear. And in the end, you put in the DJ stent. You can see here the double J stent is now being inserted, and that double J stent will be left in place so that if there are smaller fragments, they can travel down. And once the procedure is done, we of course have to take another shoot and we have to see whether all the fragments have been cleared out or not. So you can see the nephroscope, you can see the double J stent, and you can see there are no more stone fragments which are visualized. So that is about PCNL, and there can be bruising which can happen, and there can be colonic injury, pleural injury if we are not careful as well. So when PCNL is done, like you saw in the video, there can be certain complications as well. And what are the complications of PCNL? The complications are bruising is the most common. Bruising is the most common complication. There can be hematuria which can occur in these patients. So hematuria can occur. Then there can be colonic injury. There can be colonic injury. There can be pleural injury and a pneumothorax formation. And there can be injury to the spleen as well. There can be injury to the spleen as well. So these are the various complications of PCNL which you should know about. Now, one thing which I want you to remember, that it is preferred in an obstructed system. We prefer doing PCNL in an obstructed system. Why? Why? Because if the system is obstructed, then the calyces would be dilated, right? in a hydronephrotic system, the calyces are dilated, and it will be easier for me to puncture that area than when it is collapsed. If something is dilated, I get a bigger target to puncture as compared to something which is collapsed. Okay, so that is why PCNL is preferred when there is an obstructed system. Now, URS or RIRS. So URS stands for ureteroscopic removal or retrieval of stone. Ureteroscopic removal or retrieval of stone is URS, and RIRS is retrograde intrarenal surgery. Is retrograde intrarenal surgery is RIRS. Okay, so if we are removing the stone from the kidney, then it becomes RIRS. If I'm removing the stone from the ureter, then it will be called ureteroscopic removal of stone. So what exactly is done here? Supposing this is the kidney, this is the ureter, this is the bladder opening of the ureter. So what I'm going to do is that I'm going to take a scope, I'm going to take a ureteroscope, and I'm going to go up the ureteric opening into the ureter, and I can remove a stone from here. Okay, I can remove a stone from here, and if I remove a stone from the kidney, then it is called RIRS, retrograde intrarenal surgery. So let me just show you a video clip of RIRS and URS, and then we'll talk about this modality more. So this is a video of RIRS shared by Dr. Raman Tanwar, who's the urology faculty in Marrow SS. And here I want to tell you that URS is ureteroscopic removal of stone when we remove it from the ureter, and RIRS is when we remove it from the kidney, retrograde intrarenal surgery, right? So first, of course, we put in a cystoscope, we catheterize, we cannulate the ureter, and you can now see this nephroscope. You can see how flexible it is, how malleable it is, and flexible it is, and we can bend it to any angle we want, and this will help us in grabbing the stone fragments which are inside the kidney. So you can see how much you can bend that nephroscope. And now we put in the ureter has already been cannulated, so we will put in our instrument along with the nephroscope. We are going to go up, and we are then going to grab the stone fragments, and we're going to bring them down. We can break up the stone fragments using laser, or we can use a Dormia basket as well. So you can see the stone there, you can see the stone here, and we can see the stone in the calyx. And now we're going to grab it with the instrument which we have, and we're going to bring down these stone fragments. Okay, so you can see that now we are going to advance our instrument. So now our instrument is being advanced through another channel in the cystoscope. That instrument is being advanced. And once the instrument has been completely advanced, we are still under vision. So everything is done under vision so that we don't create false passages, we don't perforate the ureter or the kidney parenchyma, and we don't cause any injury. So everything will be done under vision. So now you can see this was our instrument, and you can see the prongs opening up. You can see the prongs have opened up, and now the urologist is going to grab the stone fragments which I showed you earlier, and they are going to retrieve the stone fragments. Right, so these are the stone fragments being grabbed, and then they will be retrieved. So that is RIRS. If you remove it from the ureter, it is ureteroscopic removal. Otherwise, it is called retrograde intrarenal surgery if you remove the stones from the renal calyces. So to remove these stones, you can even see here, I showed you the PCNL video. This is the PCNL image. This is RIRS. You can see the stone. This is after the stone has been removed. And this is ureteroscopic retrieval, where you can see the stone is being retrieved from the ureter. Now to retrieve stones, we can use a Dormia basket. Right, we can use a Dormia basket to retrieve the stone. This is a Dormia basket which you can see, which can be used to retrieve a stone. Lasers can also be used to shatter stone or break stones in the renal system. And these lasers are the holmium YAG laser. So Holmium-Yack lasers can also be used to break renal stones and ureteric stones. Now, let me just summarize the treatment for you, summarize the treatment of renal stones, because this will help you answering MCQs which have been asked in the exam, and specifically the AIMS and the INI-CT exam. They had asked a lot of MCQs regarding the management of renal stones. So I've told you, if the stone is less than 5 to 6 millimeters, patient is asymptomatic, then in these patients we just have to do observation, nothing else is to be done. The stone will be passed on its own. But if it is a large stone, or if the patient is symptomatic, if it's a large stone or the patient is symptomatic, then in these patients what we need to do is, the first line of treatment for these patients is ESWL, extracorporeal shock wave lithotripsy. Now, if ESWL fails or is contraindicated, if it fails or if it is contraindicated, then we have two options. The options available with us are PCNL, or we have RIRS or URS. Okay. PCNL, I've told you, is preferred in an obstructed system. It is easier to do PCNL. So in an obstructed system, we can do PCNL. Otherwise, we can do RIRS or URS. And that is how we decide, we take a call regarding the management of renal stones. Now, whenever renal stones have been taken care of, we will always put in DJ stents, double J stents, I have told you, because there can be small fragments which are left behind and they can easily travel down through those stents. And also this prevents fibrosis in the ureter after any procedure and prevents strictures. Now, I'll be covering about ureteric stones and bladder stones here as well. So there can be stones in the ureter also, and these stones also you can pick them up either by NCCT or like you can see on a X-ray KUB as well. But the investigation of choice will be NCCT, non-contrast CT scan. Now, there can be certain differential diagnosis of these ureteric stones. These can be foreign bodies, they can be ingested pills, it can be a calcified 12th rib, which can also mimic a stone. And sometimes these can be confused with GB stones on the right side. They can be confused with GB stones. And in the final year Viva, when they show you an X-ray of a ureteric stone, the examiner can ask you, how can you differentiate it from a gallbladder stone? So if they ask you a question like this, your answer should be that I would like to see the lateral film. When we see the lateral film, you will see gallbladder stones will be anteriorly placed. They will be anteriorly placed, whereas if it is a ureteric stone or a pelvic stone, they will be posteriorly placed. They are going to be placed posteriorly. Also, you should know that only 10% gallbladder stones are radiopaque, whereas 90% renal stones are radiopaque. So that can also be a hint towards identifying whether it's a GB stone or a ureteric stone. Now, the management of ureteric stones, if again it is less than 5 to 6 millimeters, we just carry out observation in these patients. But if the patient is symptomatic, and if the stone is more than 5 to 6 millimeters, then the first line of treatment is URS, that is ureteroscopic retrieval or removal of stone, which I've already told you. So first line is URS. Now, if URS fails, or if the stone is impacted and it is not budging from its position, then we have to carry out a ureterolithotomy. This is rarely done. Majority of the times the stone is managed by URS only, by ureteroscopic removal of stone. Now, in ureterolithotomy, if this is the ureter and this is the stone, please remember that we have to make a longitudinal incision and not a transverse incision to remove the stone. Okay? Why longitudinal? Because if you make a transverse incision, how will that heal? It will heal with stricture formation. So never a transverse incision. We use a longitudinal incision, and we will use absorbable sutures to close this. Why absorbable sutures and not non-absorbable? So non-absorbable sutures, if you use, that suture will remain in place forever, and that will act as a nidus for stone formation. That suture itself will act as a nidus for stone formation. That is why absorbable sutures should be used longitudinal incision, and the knots should be on the outside of the lumen. So this is how we manage ureteric stones. Now you can have bladder stones as well, and this you can see the bladder stone. Remember I told you bladder stones can increase in size, and you must, if you've seen a paperweight, you should ask your professor if it's a bladder stone or not. So if you've seen a paperweight on your surgery professor's desk, it can very well be a bladder stone as well. So bladder stones can be of two types. So bladder stones can be of two types. You can either have primary bladder stones or you can have secondary bladder stones. Primary bladder stones are ones which are formed in the bladder. They are formed in the bladder and they are formed in non-infected urine. They are formed in non-infected urine. This is usually seen in children. This is usually seen in children, and the composition is mixed urate stones. The composition is mixed urate stones, and these mixed urate stones are the most common stones in the bladder. This question has also been asked in the exam. Secondary stones are stones which drop from the kidney, which can drop from the kidney. So they are secondary to renal stones, or they can be formed secondary to infected urine. They can be secondary to infected urine, or they can be secondary to bladder outlet obstruction. Now, if there is obstruction, if there's bladder outlet obstruction or benign prostatic hypertrophy, the urine can stagnate, and that can give rise to secondary stone formation. Now, these secondary stones, infected stones, can be phosphate stones. So they can be phosphate stones which can be there. And sometimes you can also have stones which can have these spiculated margins. These are known as jack stones. These are known as jack stones. And remember I told you in kidney, which stones were having spiculated margins? Correct. So calcium oxalate stones. So calcium oxalate stones can also be there in the bladder. Now, how does a patient present? The clinical features, the patient can come with pain and hematuria. Pain and hematuria can be the clinical features. The investigation of choice, I've already told you, is a non-contrast CT scan. Like I showed you, you can even see it on an X-ray KUB, but the investigation of choice is the non-contrast CT scan. And the management of bladder stone, the first line of management of bladder stone, the first line of management is per urethral cystolithotomy. Per urethral cystolithotomy. So if this is the urethra, this is the bladder, we are going to go up the urethra. We will go up the urethra. We will shatter the stone and we will retrieve the fragments. Okay, we are going to retrieve the fragments. So this is the first line of treatment. But when it is contraindicated, then we will use suprapubic cystolithotomy. And what are the contraindications? Contraindications are if there is a urethral stricture. So if there's a urethral stricture, your urethroskop will not go inside only, your cystoscope won't go inside only. If it's a stone in a bladder diverticula, so it will be difficult for us to access the stone if it is a stone in the bladder diverticulae, or if it is a failed if it is a failed perurethral cystolithotomy stone. So you try perurethral cystolithotomy, but it fails because maybe the size was more, or the stone could not be shattered, or fragments could not be removed. Then in these patients, we have to carry out a suprapubic cystolithotomy. We have to carry out a suprapubic cystolithotomy in these patients. So this was the management of renal stones, ureteric stones, and bladder stones. And like I told you, invariably one question is definitely asked from this topic. Now the final topic which we need to talk about in this module is vesico-ureteric reflux. So vesico-ureteric reflux is seen in 3 to 5% girls, whereas 1 to 2% boys can show vesico-ureteric reflux. So less than 3 months of age, This is more common in boys, whereas more than 3 months, it is more common in girls. Vesico-ureteric reflux means that the urine is going up. Urine is going in the opposite direction. Instead of urine going forward, some amount of urine is going up the ureter. That is vesico-ureteric reflux, right? And there are various grades of vesico-ureteric reflux. And this we can figure out on IVU, intravenous urogram, or MCU. MCU is micturating cystourethrogram. Which can tell us whether there is reflux happening or not. Okay. So there are 5 grades. Grade 1 is when there is reflux into a non-dilated ureter. Grade 2 is reflux into the pelvis, but there's no distension. So see this, grade 1 is a reflux into non-dilated ureter. You can see this is the reflux which is happening. This is into the pelvis, but there is no distension. That is grade 2. Grade 3 is when there is mild distension. Grade 4 is when there is blunting of calyces or tortuous ureter, that means hydronephrosis. And 5 is when there is gross distension of the ureter along with loss of papillary impressions. That is grade 5. So you can see here, this is grade 3 is when there's mild dilatation, 4 is when hydronephrosis and blunting has started, and 5 is when there's loss of papillary impressions. That is grade 5 vesico-ureteric reflux. Now on imaging you can see here, this you can see is a patient with grade 5 vesico-ureteric reflux, which I just told you can see on imaging. Now how do these children manifest? So the clinical features, when the urine goes up, when the urine refluxes into the upper urinary tract, this can give rise to pyelonephritis, right? And this pyelonephritis patient can come with pain, fever. These patients can have recurrent UTIs. Now, if this pyelonephritis is not managed properly, then this pyelonephritis can give rise to renal scarring, and that can permanently hamper the functioning of the kidney. It can give rise to renal scarring and it can hamper the functioning of the kidney as well. So this is the presentation of vesico-ureteric reflux. And how do we manage these patients with vesico-ureteric reflux? So it can permanently damage the kidney and it can give rise to renal scarring. And these patients with renal scarring can develop chronic pyelonephritis. And they can also develop hypertension. These patients can also develop hypertension because of this renal scarring. Now, the management of vesico-ureteric reflux, if it is a grade 1 to 3 vesico-ureteric reflux, all you require is antibiotic prophylaxis. But this antibiotic prophylaxis should be started timely so that renal scarring or damage does not occur. So antibiotic prophylaxis, and majority of the patients resolve. In majority patients, it subsides with time. Grade 1 to grade 3, it subsides with time. But if it is grade 4 to grade 5, vesico-ureteric reflux which is there, then in these patients also we start with antibiotic prophylaxis. But these patients usually require some sort of intervention. Okay, they require some sort of intervention, and the intervention can either be in the form of endoscopic methods, or it can be open surgical methods, or it can be open or laparoscopic surgical methods. So the 2 endoscopic methods which are used are sting and hit, whereas the open surgical method is reimplantation of the ureter. And when we implant this ureter, we do it in a manner so that reflux does not occur. And that technique of reimplanting the ureter is known as the Leadbetter-Politano technique. So the method of reimplanting the ureter so that there is no reflux which occurs is known as the Leadbetter-Politano technique. Now the 2 endoscopic methods are sting and hit procedure. So STING procedure stands for subureteric. STING stands for subureteric Teflon injection. Teflon injection is STING procedure. So you can see here, this is STING when we subureterically put in a compound so that reflux is prevented. And earlier on, Teflon was used, but now we use Deflux. Deflux is the compound which is injected there so that your reflux does not occur. And the other technique is HIT. HIT stands for hydrodistension implantation technique. So this is hydrodistension implantation technique. These are the two endoscopic methods or the minimally invasive methods how we can deal with reflux, and this is mainly required for grade 4, grade 5 reflux. Majority of grade 1 to grade 3 will just respond to antibiotic prophylaxis. Before we end this module, for final year students, what is important in this module? So short notes you can get in polycystic kidney disease, you can get horseshoe kidney. I told you long questions from this module are hydronephrosis, renal stones are all long questions which you can be asked, and you can even be asked about vesico-ureteric reflux. This can either be asked in surgery or in the pediatrics exam as well. Now, before we end the module, let's quickly do some questions. So, a child is brought to the clinic for evaluation of recurrent UTI. The intravenous urogram is shown below. What is the most likely diagnosis? This, is duplication of the pelvic system, which can give rise to your drooping lily sign. This is a drooping lily sign, which we have spoken about. Which one of the following statements is true regarding the condition shown in the image? We know this condition is when the lower poles of the kidney are joined. We get the horseshoe kidney. All patients should undergo resection of the fused portion. Wrong statement. Majority patients are asymptomatic and incidentally detected. This is true statement. Adrenal glands are also in the ectopic location. This is wrong. Right, so adrenal glands are not in the ectopic location. Adrenal glands are in the normal location here. So you should remember this, adrenal glands are in the normal location. Inferior mesenteric artery restricts the ascent. This is a true statement. What will be the preferred management in a patient with grade 3 vesico-ureteric reflux? So grade 3 antibiotic prophylaxis alone is enough. Which of the following statements is not true regarding VUR? All patients with grade 3, grade 4, grade 5 require endoscopic procedures in addition to antibiotic prophylaxis. This is false. This is not true. Sting and Haze are the two types of endoscopic procedures. This is true. I just told you. DMSA scan is the best investigation to evaluate renal scarring due to VUR. This is true. I told you S for scarring. S tells us about the structure or scarring. So DMSA is correct. Leadbetter Politano can also be used to prevent reflux. This is also a true statement. Investigation of choice in a patient having ureteric stone is NCCT. This we've discussed. A middle-aged lady comes with renal stones and is admitted to the hospital for evaluation. You can see such crystals. These crystals, like glass shards, random crystals, are seen in patients with uric acid stones. This was asked in the INI-CT exam. This was a question in the FMG exam where they'd shown these envelope-shaped crystals, and we know that these are calcium oxalate dihydrate crystals. A lady comes to the casualty with left-sided colicky, low in pain, radiating to the vagina and the thigh. It reveals a 1 centimeter stone in the lower ureter. Ureteric stone is there. How will you manage this patient? I told you ureteric. We will do URS, ureteroscopic removal of the stone. Which of the following statements is false regarding stones shown in the image here? This is a staghorn stone, which I told you. Coffin lid tip type of crystals is true. Secondary to infection by Proteus is true. Formed in acidic urine is false. It is formed in alkaline urine, and it is calcium, ammonium, magnesium phosphate. This is true. So these were some questions which I wanted you to know, and that brings us to the end of the first module. In the next module, we'll talk about infections, trauma, and tumors. Thank you.